joining us today. We're really excited to have Dr. Tiffany Cortes speaking to us today. Dr. Cortes is an assistant professor of medicine in the Division of Endocrinology and the Salmon and Barshop Institute for Longevity and Aging Studies at the UT Health San Antonio. She's a joint appointment at South Texas VA with the Geriatrics Research Education Clinical Center. She completed her medical training at UT Health San Antonio, her residency in internal medicine, University of Texas Medical Branch, and endocrinology fellowship at Mayo Clinic. She is active in teaching, clinical care, and research. Dr. Cortes' research focuses on understanding the relationship between insulin resistance and functional decline in older adults and interventions to address metabolic dysfunction in older adults. So welcome, Dr. Cortes, and we'll let you take it away.
Thank you so much for that introduction, and thank you so much for the invitation to be able to talk with y'all, and hopefully you find the next 45 minutes or so interesting. And so I'm going to be talking about my area of interest, insulin resistance and aging. Hopefully by the end of the talk, I have accomplished for you to be aware of the prevalence of type 2 diabetes in older adults, appreciate the relationship of insulin resistance and sarcopenia, as well as understanding non-glycemic benefits of GLP-1 receptor agonist. So although I'm an endocrinologist, and this is near and dear to my heart, I do think that everyone would appreciate the effect of type 2 diabetes and the importance of this. When we take a look at the prevalence of type 2 diabetes in older adults, nearly over a quarter have diabetes, and almost 50% have pre-diabetes. And so this is resulting in almost 3 to 4 older adults having some type of insulin resistance. Additionally, the graph on the right shows that it's not just people are diagnosed when they're middle aged or younger adults and they're progressing with this diagnosis of type 2 diabetes as they're getting older. We're seeing that people are still being diagnosed with type 2 diabetes as we get older. And to look a little bit more about why this is happening, what is underlying this increase of diagnosis of type 2 diabetes in older adults, I wanted to talk a bit about factors relating to this. And so one, as we get older, we know that there is a decline in beta cell function. And so that means that somebody is not able to produce as much insulin. Additionally, with aging, there's a few risk factors that become more prevalent in this population. One, decreased physical activity. We also have increased adiposity, decreased muscle mass. Additionally, there are comorbidities that lead to increased risk of type 2 diabetes, as well as inflammation. There are genetic risk and background factors that increase the risk that really people aren't able to change that much. And so all of these diabetic risk factors result in insulin resistance. And so when you combine that insulin resistance with the decreased ability to produce as much insulin, then we can get pre-diabetes or overt type 2 diabetes. Next, taking a look a little bit further about muscle and the relationship with muscle and type 2 diabetes. We know that healthy adults lose about 8% of their muscle mass per decade between 40 and 70 years old. And this graph is showing that after age of 70, that increases to about 15% per decade. And so all of this is relating to for older adults, there's usually less muscle for glucose to be driven into by insulin. Additionally, something that most of us are probably familiar with is the obesity epidemic across America. But additionally, we see that 41.5% of adults 60 and older are obese as well. And being in Texas, and as you can see, Texas is bright red, we have significant levels of obesity, and especially with the relationship with obesity and the higher risk in the Hispanic population. So this is something that I see very commonly. Now, although many of us are probably familiar with the diagnosis of diabetes and pre-diabetes, I just want to make sure we're all on the same page and go through the criteria laid out by the American Diabetes Association. And so The diagnosis of diabetes, if you don't have somebody with like overt hyperglycemia, having signs and symptoms, a lot of this is just based off of screening. You can diagnose someone with diabetes if they meet 2 of 3 of the following: a fasting plasma glucose greater than or equal to 126, 2-hour postprandial glucose greater than 200 that's obtained during oral glucose tolerance test, or hemoglobin A1C greater than or equal to 6.5%. Additionally, you don't need 2 separate criteria to meet the diagnosis of diabetes. You could just have repeat measurement of a hemoglobin A1C at a different time point, and if it meets the criteria, then somebody falls into that category of having type 2 diabetes. Prediabetes is based off of a fasting plasma glucose between 100 and 125, a 2-hour postprandial glucose between 140 and 199, or a hemoglobin A1C between 5.7 and 6.5%. Sometimes we have just one of the measurements being abnormal, and so if we see that somebody only has the elevated fasting plasma glucose, and that's where somebody may be termed to have impaired fasting glucose. Additionally, if somebody just has a 2-hour postprandial glucose that's abnormal, then they may be termed to have impaired glucose tolerance alone. Now, I was mentioning just about half of older adults have prediabetes. And now let's take a look at what can let us know who's at the highest risk of having progression to type 2 diabetes. As I was mentioning, the criteria for type 2 diabetes is the hemoglobin A1C above 6.5%. So if we have somebody that's already at the higher end, between 6 and 6.5%, then the 5-year incidence of progression to type 2 diabetes is about 25 to 50%, or on an annual basis, about 8 to 9%. Specifically taking a look at older adults in a study that was done outside of America, they looked at older adults with prediabetes to try to determine what was the progression, reversion, what happened to this population. Those who were more likely to progress from prediabetes to type 2 diabetes were obese, and those that were more likely to have regression from prediabetes to normal glycemia were more likely to have a lower blood pressure, healthy heart, or having weight loss. Lastly, with talking about diagnosis of type 2 diabetes, although most commonly we just use hemoglobin A1C or fasting plasma glucose to diagnose type 2 diabetes, this can really underrepresent the older adults who truly have type 2 diabetes, and this is most reflected in an oral glucose tolerance test. Now, understandably, it is easier just to have somebody say, hey, don't eat breakfast, go to the lab, go get your blood work and get one blood draw, and we're able to get a fasting plasma glucose and a hemoglobin A1C pretty quickly and painlessly. But to proceed with a 2-hour glucose tolerance test, you're fasting, and then you're at least in the lab for 2 hours and not having the best tasting glucotrol ingestion. Endocrine Society recommends that for older adults who have an abnormal hemoglobin A1C or a fasting plasma glucose, that they actually be recommended to get a 2-hour oral glucose tolerance test, or to consider it a little bit more aggressively, because we know that that's going to more likely correctly diagnose older adults with type 2 diabetes and not just having prediabetes. And what this survey is from the N. Haynes from 2005 to 2016, and was comparing when we took a look at just the standard approach with a hemoglobin A1C and a fasting plasma glucose, we diagnosed older adults with type 2 diabetes about 8%, compared to if we had the addition of the oral glucose tolerance test. Then in the over 75 population, we're actually looking that there is a prevalence closer to 20%. Now, after we've diagnosed somebody with type 2 diabetes, what are our goals? Well, just a second. We're so commonly used to the goals for type 2 diabetes management to be a hemoglobin A1C less than 7.7%. And even for some conditions, such as when you're pregnant, is lower, 6.5, 6%, and we really try to drive down that glucose. In older adults, We take a look at more about who is the person in front of us. Instead of just having usually that blanket 7% goal, we take a look at, are they healthy? Are they having more comorbidities? Or possibly are they at the end of their life, to try to determine what is most appropriate for them. Because glycemic goals are really trying to prevent the long-term outcomes of uncontrolled diabetes and having increased risk of nephropathy, neuropathy, retinopathy. If you have somebody who's an older adult, let's say in 75, who has multiple comorbidities, then you're expecting that even if their diabetes isn't under excellent control, that they may not be facing those long-term outcomes. And so you may not want to treat them as aggressively. But as we know, older adults are a wide population. We have people who would be running marathons in 70 and 75-year-old, or people who are overall healthy, very active, who may have diabetes. And for that population, you're expecting them to have a longer life expectancy. And so a reasonable hemoglobin A1C goal would be between 7 and 7.5%. Versus as we get to more complex, then we get to a little bit more relaxed hemoglobin A1C and glucose goals for 8%. And if you have somebody who's very complex or at the end of their life, then really we're just trying to prevent symptomatic hyperglycemia and trying to keep glucoses under 200 and mainly trying to avoid hypoglycemia. But it's not just about glycemic goals anymore. We're really able to tailor treatment of type 2 diabetes medications to the patient in front of us. And what are they having comorbidities? What are their concerns about? And so you may be having somebody who you're really just concerned about glycemic goals, that their sugars, you saw them in the hospital with diabetic ketoacidosis, and their sugars are in the 4 or 500s or 4 or 500s versus somebody who maybe is just early on, newly diagnosed, or has relatively controlled type 2 diabetes, but they have other comorbidities such as obesity, or you want to decrease their cardiovascular risk, or you want to help to prevent progression of chronic kidney disease. We have medications that are FDA approved not only for type 2 diabetes, but also to help those conditions as well. And so looking at GLP-1 receptor agonists first, although this is approved for type 2 diabetes, there are additional indications. One would be for treatment of hyperglycemia, as well as reduction of major adverse cardiovascular events. Additionally, GLP-1 receptor agonists are by themselves just FDA approved for chronic weight management without the need to have type 2 diabetes. Another newer class of medication, SGLT2 inhibitors, are well known not just for their control of hyperglycemia, but additional benefits. FDA approval for type 2 diabetes, in addition to helping to prevent chronic kidney disease, progression of chronic kidney disease, reduction of major adverse cardiovascular events, as well as reduction of hospitalization and death from heart failure. So really, these newer classes of medication have gotten us not just to think about hyperglycemia, but to also think about how can we really optimize type 2 diabetes management for our patients, and what can we use to help them best achieve their goals. As I was talking about earlier, that frequently with tight glycemic control or trying to have a hemoglobin A1C less than 7%, we are looking to prevent long-term complications such as the neuropathy, nephropathy, retinopathy, but we know that other diseases are also associated with type 2 diabetes, such as cardiovascular disease. And so I kind of group those together as the usual suspects, that you talk to anybody that they have ways to look for kidney disease, they're monitoring, do they have eye disease or any nerve disease, cardiovascular health. But specifically for older adults, there are additional concerns that don't necessarily come up to the first of your mind when you're thinking about comorbidities related to insulin resistance. And especially for older adults, we want to be thinking about sarcopenia and frailty. And to define sarcopenia, this is age-related decline in skeletal muscle mass with decreased strength and or function. Underlying mechanisms of sarcopenia are multiple. We have oxidative stress, inflammation, inactivity, disuse, change in hormones and growth factors, apoptosis, microvascular changes, as well as mitochondrial dysfunction leading to this syndrome. But although this is a very important consideration, especially for older adults, there are a few different definitions as opposed to when we take a look at just the diagnosis of type 2 diabetes, and we have these very strict cutoffs. For sarcopenia, the European Working Group on Sarcopenia in Older Adults defined it as low muscle mass and low muscle quantity and or quality, and low physical performance adds severity to the diagnosis of sarcopenia. For Asian Working Group on Sarcopenia, they defined it as muscle strength as well as low muscle strength as well as low muscle mass. For them, they set criteria for grip strength as the definition of muscle strength. And for muscle mass, they set definitions for DEXA or bioelectrical impedance analysis. Now, you could have both of those to qualify for the diagnosis of sarcopenia, or you could have a low physical performance as measured by a 6-minute walk, a 5-time chair stand, or short physical performance battery. Lastly, for the foundations for NIH, they defined sarcopenia as low grip strength and low appendicular lean mass when adjusted for BMI, and they also gave cutoffs for these areas. And so although we have a few definitions of sarcopenia, I don't think anybody would argue that this is not an important disease to take a look at. We know that those who have sarcopenia are more likely to have falls, fractures, impaired ability to perform activities of daily living, cardiac disease, respiratory disease, cognitive impairment, lower quality of life, loss of independence, or death. And really, we want to try to help to manage sarcopenia and treat sarcopenia to prevent these adverse outcomes, especially for older adults. This is going back to the graph that I showed earlier, where we talked about that per decade of life, we see decreased decreased muscle mass of about 8% below 70 years old, and above 70 years old, we see about a 15% decrease in muscle mass per decade. But what we also see, looking at the graph on the left-hand side, is although there's that decrease that occurs with the muscle mass, we also see significantly greater losses of muscle strength compared to just the loss of muscle mass in and of itself. Now, when we were taking a look at some of the underlying factors of diabetes and some of the underlying factors of sarcopenia, you can tell that there appear to be some things that were common to both of them. This is a meta-analysis taking a look at just the association between sarcopenia and diabetes for those populations who had diabetes or who had normal glycemia. And we see that type 2 diabetes was significantly associated with the diagnosis of sarcopenia. Taking a look at a little bit more at the physical function component, taking a look at physical function and diabetes, this was a study with 92 men, average age of 70 years old, and who were categorized as normal glycemia or type 2 diabetes. Those who had normal glycemia had an average hemoglobin A1C of 5.5%, and those who were classified as type 2 diabetes had an average hemoglobin A1C of 7.2%. And on the right-hand side, we see a few different areas of physical measures, such as leg extension to stand time. And we see that those with diabetes had significantly poor measurements in the leg extension to stand time, as well as hand grip strength, although there was not a significant difference seen in leg press. The San Antonio Longitudinal Study of Aging is an observational study that had its baseline exam in 1992 between 1992 and 1996, and then they followed up this cohort over 3 exams that occurred between 2000 and 2005. It was a comprehensive assessment of the disablement process, and it was unique in that it had this bi-ethnic cohort, 394 Mexican Americans and 355 European Americans. In this cohort, in this also cohort, when they took a look at glycemic control and physical function, there was 119 participants who were able to have hemoglobin A1C and functional measures that were followed up and obtained over 36 months. They were then classified into better control or poor glycemic control. Those who had better glycemic control all had hemoglobin A1Cs less than 7%, and those with poor glycemic control all had hemoglobin A1Cs greater than 7%. And the better glycemic control group had greater maintenance in the short term and long term of their short physical performance battery. This is taking a look at comparing prediabetes to diabetes to normal glycemia. In this population, we had an average age between 48 for diabetes, 37 for prediabetes, and 32 for normal glycemia. So not quite older adults, but a good, very interesting when we start to take a look at muscle mass and function. When we take a look at mass, for these groups, there was not a significant difference between just the kilograms of lower limb mass between the 3 groups. But when they took a look at contractile quality, which is muscle strength over the mass, then that's where we were seeing significant declines when we compared not only normal glycemia to diabetes, but normal glycemia to prediabetes. And we see that those who have prediabetes and diabetes look much similar compared to those who had normal glycemia alone. Then what I also think is interesting is when you take a look at the hemoglobin A1C. As expected, those with diabetes had much higher hemoglobin A1C of 8.6%, but those who had prediabetes had an average hemoglobin A1C of 5.7%, and those with normal glycemia had an average hemoglobin A1C of 5.3%. So it's not the stereotypical hyperglycemia that you would expect to possibly be associated with these changes. This is in America, the NHANES population, and taking a look very similarly, comparing normal glycemia to prediabetes to type 2 diabetes. The average age here was a little bit older, and 43 for those who did not have sarcopenia and 52 for those who did have sarcopenia, with a difference of a hemoglobin A1C 8.6% compared to 5.7%. And on the right-hand side, when we take a look at these different groups, when we take a look at the prevalence between sarcopenia, we see that for prediabetes, there was an increased prevalence of 11.8% compared to those who had normal glycemia, which was 5.1%. And as expected for type 2 diabetes, an even high percentage of 22.37%. And these differences maintain when we looked both at men and women, that those who had prediabetes were more likely to have sarcopenia compared to those who had normal glycemia. And similarly, those with type 2 diabetes were more likely to have sarcopenia compared to those with normal glycemia. As I was mentioning a little bit earlier, sometimes the changes in hemoglobin A1C aren't very drastic for us to start to get some change with muscle mass or muscle function. This is taking a look at the association between hemoglobin A1C and muscle mass. And we see that we don't really want people to have very low hemoglobin A1Cs below 5% because that can be an indicator of malnutrition. But even at 5%, we see that there is an inflection point that as we get above 5%, that they were showing decreased muscle mass. And this doesn't even go up to where we see a lot of patients with diabetes in the 7 to 8 range. And so overall, these studies have been showing the interaction between type 2 diabetes and sarcopenia and how they're intricately related. And that when we have diabetes, there are factors that lead to sarcopenia. The insulin deficiency, which is having a catabolic effect, with diabetes having increased plasma-free fatty acids, inflammatory cytokines, decreased fatty oxidation, decreased mitochondrial oxidative capacity, all contributing to sarcopenia, and then sarcopenia leading to increased skeletal muscle resistance, which is leading to the requirement of higher levels of insulin, which is then leading to put further stress on the beta cells, which is leading to the inability of the beta cells to function appropriately, leading to hyperglycemia and diabetes again, and you can see this circle going round and round. I wanted to touch base a little bit on frailty as well. This graph is just showing the relationship between sarcopenia and physical frailty. Now, the frailty is something that this audience is very familiar with. To go through the definition, frailty is a geriatric syndrome known to increase risk for disability, hospitalizations, and death. The physical phenotype of frailty is defined as the presence of 3 or more of the following: unintentional weight loss, exhaustion, weak grip strength, slow walking speed, or low physical activity. And you can see why that overlap between sarcopenia and frailty is present, with the consideration that weak grip strength, slow walking speed, and low physical activity are all physical characteristics of frailty. We know that there is a strong relationship between insulin resistance and frailty. And longitudinal prospective studies have shown that older adults with diabetes compared to those without diabetes are more likely to develop frailty, as well as having worsening frailty levels. There was longitudinal observation of older women that showed that those with diabetes had a 40% increased chance of becoming frail compared to those without diabetes. In SALSA, this was shown that those with diabetes were shown to be predictive of gaining 1 or more frailty characteristics. And lastly, it has been shown that those with diabetes or high hemoglobin A1C levels were more likely to be associated with higher frailty trajectories. And so all of this is leading to the background with insulin resistance, as with sarcopenia, with frailty, and coming to my pilot study that was funded through my RL5 scholarship. And this study is the effect of GLP-1 receptor agonist on physical function, body composition, and biomarkers of aging in older adults. In older adults who are overweight, obese, with insulin resistance. Now, just a spoiler, this pilot is still ongoing, but I wanted to talk a bit about it for this presentation. One, why did we feel that it was important to take a look at this population and the effect of GLP-1 receptor agonists? We know that commonly older adults aren't appropriately represented from clinical trials that try to approve medications and try to get FDA approval. And so this is taking a look at clinical trials for medications that were being sent to the FDA for approval between 2010 and 2019. On the left-hand side, the dark blue bars represent the prevalence of that age group for the clinical trial. And the light blue bars represent the prevalence of type 2 diabetes just across America. Then we see an overrepresentation of those 45 to 64. When we get to the age group of 65 to 74, we see that we're still not having the appropriate representation, but it is better than when we take a look at the over 75 population. Over 75 is really underrepresented for clinical trials. On the right-hand side, this is a graph showing the participation to prevalence ratio, and a common goal that is stated is to be between 0.8 and 1.2. And similarly, we see that overrepresentation of middle-aged adults, and with 65 to 74, we are barely meeting the cutoff for appropriate representation, but really in over 75-year-olds, we are not having appropriate representation in these clinical trials. And so also we wanted the study to be focusing on older adults to really take a look at these widely used medications that are already being prescribed and seeing what are the changes we see when we take a look specifically at older adults. The aims of the study were to conduct a pilot study to examine the effect of GLP-1 receptor agonist on physical function and body composition in older, overweight, obese adults with prediabetes or well-controlled diabetes, and then additionally to examine the impact of GLP-1 receptor agonists on biomarkers of aging in this population. I wanted to review a little bit further about the mechanism of action of GLP-1 receptor agonist. So GLP-1 receptor agonist has an effect on multiple areas. First, and this is when you're giving it to patients, you're going to be talking extensively about the most common side effect of GI symptoms of abdominal pain, nausea. And a lot of this is relating to the decreased gastric emptying that is initially seen when you start this medication, or at any time that you start to increase this medication. Then we also see that GLP-1 receptor agonists have an effect to increase insulin secretion and decrease in glucagon secretion. What is very important about this class of medication is that although it increases insulin secretion, it increases insulin secretion in response to hyperglycemia. And so this medication, even though it is still present in the body when somebody isn't eating or their glucose is under control, it's not resulting in increased insulin secretion as opposed to some other medications. And so the GLP-1 receptor agonists are very nice because in and of themselves, they really should not cause hypoglycemia. Additional effects that we see are in the muscle, increase insulin sensitivity. In the liver, we have decreased glucose production. Also in the heart, we see cardioprotection, increased cardiac output. And in the brain, this, as I was mentioning earlier, this class, some of the medications in this class are FDA approved for chronic weight management alone. And frequently people think that the weight loss that we see is related to the GI symptoms. But as a lot of people will tell you, the GI symptoms of the nausea, abdominal pain, change in bowel habits really usually improve after weeks to months. And so in the long term, people really should not be having those symptoms. And if they are having those symptoms, and I say, maybe this class of medications isn't the best for you. But really what's producing the long-term outcome of chronic weight management is the decreased appetite that is seen, that people will say they're like, I'm already eating less, I don't feel hungry, I'm not feeling like I need to snack. And so this medication has multiple effects. As you can see, not just glycemic effects. Other effects of GLP-1 receptor agonists, that possibly we have neuroprotective effects in those with type 2 diabetes, particularly under 65. In mice that were modeled to have muscular dystrophy, there was shown to be improvement of skeletal muscle atrophy. Additionally, we see improvement of the pro-inflammatory milieu with decreased levels of C-reactive protein, tumor necrosis factor alpha, as well as adiponectin. As I was mentioning, GLP-1 receptor agonists some of them are FDA approved for weight loss by themselves, but really we see weight loss with any medication in this class. And as we know, with weight loss, usually we also lose some lean body mass. And as I was mentioning earlier with sarcopenia, that's not necessarily something we want to propagate, especially for older adults. And what this meta-analysis is taking a look at is some of our oldest GLP-1 receptor agonists, exenatide and liraglutide, and trying to look at how much weight is being lost from adipose versus with lean body mass. And so the black is the percentage of weight that was coming from just adipose alone, and the white bar is a proportion of total weight loss comprising lean body mass compared to fat-free mass. So overall, we want a longer black bar and a shorter white bar. And we see that with even within liraglutide or within exenatide, there isn't consistency that we're seeing that there's significantly more lean body mass, or that there is just a significant loss of adiposity alone. And there was only one study taking a look at semaglutide, and I'll talk about that next. Looking at semaglutide and body changes, this was 30 participants who underwent a 12-week crossover treatment, and they either first had semaglutide up to 1 milligram, then had placebo, or vice versa. All of them did not have diabetes. Their hemoglobin A1Cs were less than 6.5%, and this was a younger population with a mean age of 42. But we see that compared to placebo, they lost about 3.5 kilograms in body fat mass compared to body lean mass of about 1.1 kilogram. Now, this study did enroll participants with diabetes, even though it was a smaller study with 11 participants. Still more in the middle age category, with an average age of 7, and their average hemoglobin A1C was 7%. And we see that this study showed significant decline in fat mass, as well as the percent of fat mass lost compared to total body weight. But we also saw decrease in skeletal muscle mass. But taking a look at the average for baseline, the skeletal muscle mass went from 29.5 to 29. Additionally, when they took a look at the percent of skeletal muscle mass loss, there was not significance seen, except it was close at a p-value of 0.06. Looking at a little bit further quality of life, there weren't as many studies taking a look at physical function measures by itself in semaglutide, but this study took a look at quality of life measures with the SF-36, and specifically the domain looking, and this is specifically looking at the domain for physical function. This was over 3,000 participants, and they were either on placebo versus semaglutide for between 96 and 100 weeks, with the average age of 65. With this, we saw significant improvements overall in the physical function domain of the SF-36, but specifically we saw improvements in general health, physical function, and decline in bodily pain. And to talk a little bit further about my pilot, this is conducted through the Salmon and Barshop for Institute for Longevity and Aging study. It is a 20-week single center open label randomized trial. Everybody in the trial gets lifestyle counseling alone, because really lifestyle counseling is the standard of care when we're taking a look at those with pre-diabetes or those with well-controlled diabetes. But half of the population will be getting semaglutide. And the goal is to have 20 participants complete the study from the community. This is just an overview of what the study is looking like. First, they come in for their screening visit, where we do screening labs, questionnaires, body composition with the DEXA, as well as functional assessments. Then if they pass the screening visit, they come back for visit 2, which is where they get randomized to either lifestyle alone or lifestyle plus semaglutide. Additionally, do muscle biopsy, adipose biopsy, obtain labs for blood draw for research, and everyone gets that lifestyle counseling. And then everybody comes back 1 month later for an in-person visit, and those who are on semaglutide are increased from the 0.25 milligrams that they were started on up to next dose is 0.5 milligrams if they're doing well. Then we have everyone come back 1 month later, get lifestyle counseling. If you're on semaglutide, we see if you can go from 0.5 milligrams to 1 milligram. And then 1 month later, they come in again, lifestyle counseling. And we just want to make sure if we're able to get up to the 1 milligram of the semaglutide, that they're doing well on it and we don't have to back down. Then we leave them alone for 2 months, and they come in for their final visits. And it's broken up into 2 visits because it's kind of a long day. We do questionnaires, body composition, functional assessments on the first visit. And then later on, hopefully within that week, then they're coming in for their final muscle biopsy, adipose biopsy, and research labs. For the assessments, for functional assessment, we're looking at short physical performance battery, 6-minute walking distance and grip strength. For questionnaires, we're doing the SF-12, as well as an appetite assessment with the CNAP. Now for the blood, muscle, and adipose, we're doing a few things. We're looking at a variety of serum immunoassays. Additionally, for the muscle and adipose, we are looking at PCR measurements of IL-6, TNF-alpha, P16, TLR4. And in the adipose, we are also doing beta-galactosidase staining to look at cellular senescence. And so where am I in this project? We started screenings April of 2023. We have 20 screenings completed. 14 have passed. Our goal is hopefully to be able to complete all visits before in early 2024. And taking a look at the baseline characteristics of those who have passed, we have an average age of 71 with a variety, with the lowest age being 66 and the highest age being 82. Right now, we are still evenly divided between men and women. We have 6 Hispanics who are enrolled, and their BMI is an average of 32, ranging from 27 to 37. Average glucose is 102, and hemoglobin A1C is 6.1. We also see that triglycerides are pretty well controlled between 75 and 212, with an LDL being 90. And so hopefully the next time I present this, I'm able to present further about what the conclusions of the study were. But for now, hopefully by the end of this talk, you're able to be aware of the prevalence of type 2 diabetes in older adults, appreciate the relationship of insulin resistance and sarcopenia, as well as understanding some of the non-glycemic benefits of GLP-1 receptor agonists. Lastly, I want to thank my wonderful mentors, Dr. Sarah Espinosa, Dr. Nick Musi, Dr. Monica Serra, which this project would not be possible without. And additionally, it truly takes a team to be able to complete even a quote unquote small pilot project, and the Barshop clinical and administrative staff have been wonderful. They've been helping with the screenings, the biopsies, follow-up. And so I am truly, truly blessed and lucky to be able to be here. And I also like to thank the support from the NIA, the Right Diversity Supplement, through the Pepper Center, and through the San Antonio GREC. And so at this time, I'd like to stop and answer any questions.
Thank you very, very much, Dr. Cortes. Very interesting talk. I'm going to open the floor to questions. I see Dr. Linder has his hand raised.
Yeah, making sure you can hear me okay.
Yes.
Great. That's terrific. Thank you we don't often think about, we tend to think about these two things as separate, and of course they're related. And one thing I'll get your reaction to, so we just wound up a trial in using electronic health record-based nudges to decrease, among other things, use of insulin and sulfonylureas among older adults who had A1Cs, who had diabetes and A1Cs below 7. Just wanted to get your reaction about that, given sort of what you presented about.
Oh no, absolutely. And that was, there was another talk that I gave looking at just like type 2 diabetes management in older adults. And I had that taken, I was like, this is something less than 7% on insulin and sulfonylureas, that we really should be looking at other medications. Of course, I'm not sure about your population. We have difficulty with insurance, medication coverage, and sometimes they're like, well, this is the cheapest medication, but really a lot of times like they're able to be covered on other medications and be covered well. And so that is excellent. And so I do wonder, for the EMR, for the nudges, what was the feedback from the providers? Because I feel like sometimes it's like that EMR and notification overload.
Yeah, I mean, we definitely get accused about, and Sarah, I don't know how much you've been a victim of, we definitely get accused of torturing our colleagues, our friends and colleagues. And we try to design stuff that's really sort of obvious, easy, and making things better for the clinicians and patients. So, occasionally we get confrontational when we're giving people feedback a little bit, but we try to make it really easy in the EHR with just like a quick justification about like, hey, if you're going to do this, okay, but just write a quick reason why. So to try to keep it really simple. So, and I think in that one metric, so allegedly over treatment in older adults, I think we've done well, and seen some improvements. So I have two questions related to what you presented. I was struck how much the figures you showed and the way you described it, the arrow is going from diabetes to sarcopenia. But I wonder, like, are we so sure that the arrow goes that direction and it's not either, there's a big arrow going the other, you sort of drew smaller arrows going the other way, but are these two things happening more simultaneously, or is the sarcopenia a precursor in some cases to diabetes?
Oh, and I think that is a great question to evaluate further, but I feel similar to you that really it is likely, I think it's that circle where we can get both diabetes leading to sarcopenia as well as sarcopenia leading to diabetes and vice versa. And it's just like they keep on egging each other on almost, where it's just progression of both conditions.
Great. Yeah. And actually I appreciate it. I'm a general internist, and this helps sort of even the way of thinking about it. Like, oh, right. Of course, we think about the muscle a little bit as an endocrine organ, but it really is. So
yes. And actually even like 3 years of fellowship and then really being at the Barshop and all the research that we do here just helps to this, I did not think about this nearly as much as I probably should have before.
Yeah, or any of us. My second question was about your list of outcomes that in your own study. I was struck by how many immune related things you're checking, and Adams P13 was there, and complement was all over the place. Like what in the world are you guys looking for, or expecting to find with all of the immune related stuff?
That is a great question. So we had a similar study looking at SGLT2 inhibitors that finished up. And so we were it was kind of that let us take a look at all of this and see, are there any in particular that will really be indicators of benefit, harm, etc. And this is really something where I think, but my mentor is Dr. Musina Espinosa, because these are expensive things to do. I was like, this
no doubt
is semaglutide is $1,000 a month, much as taking a look at these additional things. And they were like, you know what, we're doing this pilot. It's like, yes, the RL5 is helping to cover a significant portion, but some of these additional measures where it's more of what are we going to see? And is this going to be able to help us to have a specific outcome or improvement or harm, etc. They're really helping to get that done.
Yeah, thank you.
Thanks, Dr. Linder. Other questions from the audience? Just unmute yourself or raise your hand or put it in the chat. Yeah, to your point, Dr. Linder, about the nudges in EPIC, I think the other piece of educating your providers is also the patients, right? These patients have been dealing with type 2 diabetes for a long, long time. And so sometimes it's hard to change their behavior as well, right? You really don't need to have an A1C of 6.5. You're 95, you're 85. You can have an A1C of 7.2. That's awesome for you, and so sometimes it's changing the patient's perception of what is necessary in their diabetes treatment, but less is more for many of them.
Yeah, go ahead, Dr. Cortes. Yeah.
Oh, no, I feel like some of my longest visits have been with older adults, type 1 diabetes, and it's like that hammer, no, lower is better, lower is better, is lower better. I was like, okay, your A1C is 6%. You're having multiple hypoglycemic episodes, you've had seizures, and I go through ADA, and I've gone through my presentations and look, this is the reason behind it. And then they come back and they're still low, and I'm like, okay, I did nothing.
There is another question in the chat here for you. Can you elaborate a little more about the differences in sarcopenia between XX and XY, or other sex dimorphic effects that you saw?
And there were definitely studies I saw that were showing that, more specifically in men, that there were lower rates of sarcopenia compared to women. I think it's one of those things where more evaluation needs to be done, and hopefully in like more of a prospective manner where we're able to look at the same intervention and what is the outcome and what is the change that we're seeing. And so what I saw was kind of all over the place. And it very well could be that there are sex differences between men and women that are leading to greater effects. But hopefully, and that's why hopefully with the study, we're also trying to enroll like equal amounts of men and women. It is a smaller study though, but maybe we'll be able to get a little bit more answers.
I would also ask about and wondering, as you showed the graph of all those different studies about different changes in body composition with GLP-1 agonists, and you know, I fear I'm just like wading into careful quantitation of the obvious. You know, combining a GLP-1 inhibitor with strength training as like a co-drug, as it were, just, you know, it's sort of almost so dumb, and you think it's so obvious what you would find, but I wonder, has anyone done that?
Not so from what I saw when I took a look at GLP-1 receptor agonist in older adults, and looking specifically at older adults, I didn't see it. And looking at the trials, one combining physical like strength training wasn't necessarily obvious, but I have to take a look at to see if there's anything more in younger adults. But absolutely, and that was even something where I was like, I would love to do combination of both of them and really seeing what is the improvement of that. But taking a step and just kind of taking a look at semaglutide itself, especially being with patients and trying to continue with lifestyle management and lifestyle changes alone, even though that is optimal, sometimes it's easier to take a medication and just saying, okay,
Yeah.
you just want to take a medication.
Yeah, I mean, it does make me think about the diabetes prevention program where you're like, okay, well, metformin worked, but they got a lot of lifestyle counseling and they didn't do that much better than the intensive lifestyle group. And we're sort of in the same boat here with the GLP-1 agonist. I would, please do that study. I would love to have that study to say to patients, it's like, actually, if you do strength training, it's just as good as GLP-1 inhibitor, or sorry, GLP-1 agonist. And if you do both, like, it's fantastic.
Absolutely. I would love to do that. One of these days. We do have a very nice gym at the Barshop related to like motor pack and this study that we have ongoing. So I was like, we have the availability.
Fantastic.
Are there other last questions for Dr. Cortes? All right. Well, thank you so much for speaking to us today and for your time. And thanks everyone for joining us today. We hope to see you all next month at our next pepper rounds. Thanks again.
Thank you so much.
Thank you, Dr. Cortes. Really great.